o'clock. So I'm going to get started in respect for everybody else's time. It's a smaller than usual group today, which means that I'd really like you to get the most out of it and ask lots of questions. Before we start, I'd like to start by acknowledging the traditional custodians of the land on which we all gather today. For us in Townsville, it's the Woolgoolakaba and Bindals people, and I pay my respect to their elders past, present and future. So welcome to the TAAHC Webinar series. We've been going at this for a number of years now, and it's really got lots of interesting things about it and lots of different topics and stuff every month, last Wednesday of every month. So just a little bit about TAAHC. For those of you who do not know, we are an NHMRC accredited research translation centre. We operate across Northern Queensland predominantly. So our members of our organisation are the 5 Northern HHSs. So that's Mackay, Townsville, Cairns and Hinterland, Northwest and Torres and Cape. We also partner with the Northern Queensland Primary Health Network and the Queensland Aboriginal Islander and Health Council and James Cook University. We also have specific research streams that you can see that are related to service delivery, unique in our patch. We're also interested in innovative health workforce issues and non-communicable and infectious diseases. What I want to point you to, for those who do not know much about TAAHC, we actually have a website that has lots of different information on it. We have lots of vlogs about what we're doing. We also have all these webinars are uploaded to the YouTube channel on the website. There are recordings and there are lots of resources. And at the end of today's presentations, we'll put up some resources and stuff that you can actually find on the TAAHC website as well. So welcome to all those to do that. Tiny bit of housekeeping. Okay, so we'll just ask you guys to mute your microphones, turn off your cameras, which you've all done really nicely until the panel discussion. The Q&A is scheduled after both of the speakers have finished speaking, so we'll have a big Q&A at the end. So there's a couple of things you can do. If you don't want to forget your question, you can write it in the chat and we can call on you in the Q&A time. Or you can just simply wait till the Q&A time and you can raise your hand and we'll call on you there. So we really want it to be as informal as possible. And I definitely want you to be able to ask your own questions unless you're super shy, in which case we'll deal with that and ask it ourselves. Not a problem. So today's speakers, I'm just going to give you a very, very quick, you are not here to hear from me. So I'm going to give you about 4 slides to talk about what we're talking about today, so to orient you a little bit. Then you're going to hear from Amy and her experiences in her work. And then you're going to hear from Leah in her experiences. So I'm really excited to present alongside these people because they're quite clever and they've done quite amazing things. So I'm going to give you a little bit about what we're talking about today. So I'm going to talk about why patient and public involvement in research, what is it and why does it matter? And I want to carefully orient you to the language that we've used on this slide. So we debated and we talked about using patient and public in this slide. And we chose that rather deliberately. For me, think things about consumers. When people talk about consumers, although it is supposed to be a really broad concept, we often speak about consumers in a very narrow focus. So when people talk about consumers, oftentimes they mean patients, right? So they mean people who have had a health condition, who are helping to inform your knowledge and your research and perspectives, give perspectives and directions. But it's actually broader than that. So I like to use the terms patient and publics, because patient would be someone who has had that health condition, right? So they're the people that you might want to engage to understand a little bit more about it. But a lot of my previous research and work has been about working in things like screening guidelines, right? So the people whose information I would particularly be interested in haven't actually been patients of that condition yet. They might be screened for that condition. So I would be hunting for people who are more in the public sphere. So we've chosen the language patient and publics, which is mapped in the literature as well, but it also gets quite conflated with consumers. So that's just food for thought. You need to think about that, and I'm sure the other two will touch on that. So one of the things I want to orient you to as well is why on earth? You know, you're going to hear today that it's not easy, it's going to be challenging, And so why do you want to do this? And Tricia Greenhalgh has suggested there are three kind of reasons why you might want to look at it. And one is the normative argument, right? It's that patients have the right to have input into their own research question, right? And that's really important, and that's the moral imperative of that statement. She also argues that researchers have a moral duty to try and address the power imbalances between patients and researchers in any of the work that they do. There's also something called a consequence argument, in that by working with patients and publics, you are actually bringing their lived experience and their perspectives of that into your research. There's also a second arm to that argument that suggests that it's actually also useful for efficiency and to improve the value of the research. And that hasn't really been tested, and it is a little bit contested, but it is suggested as a consequence of you involving patients is that it's more efficient and it adds value to your research. And then finally, you've got the political and practical argument, which says that contemporary science should actually be co-constructed with patients and public because it increases accountability and transparency of your research. So Tricia suggests there are three primary reasons why it's good to do this. And then we get to that who question, which I touched on earlier. Who? And I think it's a very, very undervalued question. People often jump straight to a person with lived experience. But like I said before, what if that's not actually what you want? So interestingly, because I work for TAAHC as the research education lead, the consumers that I work for aren't actually the people who experience the healthcare directly. I work for the staff and the clinicians of the HHSs and Quake and the PHN and James Cook. So they are my consumers, right? So who is it that you need to get input into when you're considering this question? Is it a community member? Is it a person who is affected by the condition that you're particularly studying? Or are you interested in getting a very broad perspective and you're looking at, what if you're looking at a statewide implementation of something? So you really need people who have big picture lenses rather than necessarily lived experience lens only. So they're just some things that you want to talk about. And my colleague Chris Stegerling wrote on this in 2015. And then we just get to my last slide, which is the how. And this is a whole host of things. You can do a whole host of things in this. Usually when we're coming to a webinar like this and we're talking about the how, we're actually going to start kind of collaborate. Collaborate's almost our bottom level of participation when we're in this kind of forum. But you can see you can also work with patients and publics from informing them, consulting with them, then the collaboration, and then we move into the stuff that's really fun, I suppose, and builds on those three whys that we spoke about earlier. And they are co-designing and they are co-leading and leading. So I think that they are really the things that you're probably going to, I definitely know, they're the things that Amy and Leah are going to talk about with you today. So that's all from me. So I'm going to stop my share and I'm going to introduce Amy to you. So Amy Brown is a research, I'm going to read, sorry, this is Amy's bio. So Amy Brown is a research fellow from the Townsville Cancer Centre at the Townsville University Hospital. She supports clinicians and researchers across medical oncology, radiation oncology, haematology, and palliative care. With a clinical background as a radiation therapist, Amy's research interests include image guidance for prostate cancer radiation therapy and health preferences. Now, in one of Amy's PhD studies, she was insightful enough to include a consumer investigator. And this is what she's going to tell you all about. Over to you, Amy.
Thanks, Ray. And I'm always happy to talk about this experience because it was really enriching for my PhD. And so my PhD involved 3 studies where I was actively seeking participants. So that included being involved in a randomized control trial, in a mixed method study, And finally, a discrete choice experiment. And it was when I was developing this discrete choice experiment that one of my academic supervisors suggested that I consider consumer engagement. So bringing on a consumer onto the research team. And so that's what we did. So Lux joined the research team for that particular study. And that was really important because a discrete choice experiment, or a DCE, is a specialized health preferences survey. So when we're asking patients about their health preferences, it's really important to have that engagement from the get-go from a patient themselves. So today I'm just going to give a really broad overview of the steps of how this went from an idea to actually working with a consumer investigator, and also reflect on some of the challenges and some of the real advantages to come out of this. So firstly, I started off by consulting with our ethics and governance here at Townsville HHS and our person-centered care lead, as well as to how we actually go about this. And I did all the training that was available at the time, as well as read extensively in the literature about involving a consumer on this project. I was putting together a funding application for this particular project. And so I budgeted in for some of the out-of-pocket costs for having a consumer investigator. And I'll talk a little bit about this later as well. So we specifically wanted a consumer investigator to join who had the lived experience of a particular technology. That was what the survey was all about. And so we sent out a letter of invite to the 5 most recent patients who had undergone that technology experience and invited them to consider participating. And it was from that we identified our consumer. So once we'd identified him, I think one of the most pivotal steps was that he and I met, first of all, just one-on-one, and we really talked about what the project was developing into at the time. And we talked about the team he was joining. So we were really aware of that potential power imbalance. And so we kind of gave him that soft introduction, I guess, for want of a better term. And we went through some of the other requirements, such as a confidentiality agreement and some of the other specific THHS requirements. But we also, importantly, spoke about both of our expectations. So what he expected, being involved in a research project, knowing that this was the first time he'd ever been part of a research team, and also what I was hoping to gain out of it. So that was a really important step. And then he joined the team. He was part of the team. So he was involved in every single research team meeting that we had regarding this DCE survey. He gave feedback on the protocol as we developed it. He really gave a lot of feedback on the participant information and consent form, particularly making sure that our lay summary was appropriate for our population. And then he continued his collaboration with us as part of the research team in 3 specific ways. So before we sent this survey out to our population, he and I sat down and did a think aloud exercise, which was really part of piloting the survey. And that was really insightful, getting his thoughts on that. We got a lot of comments given, free text comments given by our respondents to this survey. So he and I did analysis together. We both did the content analysis and we both coded those comments together. And then he was involved in all of the interpretation discussions when we did all the analysis and we were looking at, well, what does this mean? He gave some really insightful comments there. And so the outcome after this survey was wrapped up was he was a listed co-author on the 2 papers that came out of this survey. And he also co-presented via video with me. This was in the days of COVID when all of the conferences were either cancelled or moved to virtual. So unfortunately, we didn't get the opportunity to present in person together, but he did present with some video content. So reflecting on some of the challenges, firstly, time. It was a huge time investment, particularly for myself on the research team, and for Lux, our consumer. He gave so many hours to this project, and I really need to acknowledge that. The other consideration and challenge was funding. So as you probably noted, when I sought funding, I didn't fund for his time. So he voluntarily gave that time, and that's a learning from this experience. But it's also something to consider around, you almost want the funding prior to even developing your project to really involve the consumer right from the get-go. Some of the other specific considerations that might apply more broadly is the confidentiality. So this it depends on the data that you're looking at for a particular research project. For my particular example, Lux didn't see any identified data, so that wasn't so much a concern. But it is something to ethically consider should
I don't recall that specific three. I was looking out of that maybe,
but also another consideration is the consumer themselves. Are they happy to be identified in things like presentations and publications as being associated with that particular health condition? So one of Lux's concerns at the start was that he felt the pressure to represent all prostate cancer patients. And certainly that wasn't our intent. And that's what we reassured, that we wanted him to bring his lived experience as we worked through this project, but we recognized that his lived experience wouldn't match every prostate cancer patient's lived experience. So we reassured him that he didn't have to speak for every single prostate cancer patient. And just another smaller consideration is some of the logistics that might come up depending on who you're collaborating with. So Lux, while computer savvy, didn't have an email set up. And so documentation review, I would print off hard copies and mail it to him, or we'd get it to him and he'd send it back. So there were just some considerations around that of how we made this collaboration work. But these challenges and considerations were far outweighed by the advantages. So firstly, having Lux involved from our research development meant that it really challenged our thinking and changed some of the aspects of our survey. And because this was the first time I was doing a DCE and learning about this particular method, it really helped solidify my understanding, because I was then also explaining it to Lux. So I had to make sure that my understanding was at a level that I could then explain it to him as well. Like I said, we got really good response rates for this particular survey and really good engagement with a lot of free text comments given. And I think that is because of Lux, because of his input in developing this survey. We made it as user-friendly as possible, and we got that really good engagement. And as has already been alluded to, I think one of the great advantages that we can work towards as clinician researchers working with patients and public is that ultimately we are researching what's important to them. So that's my perspective. I'd now like you to hear from Lux himself.
Well, it's enlightened me to find out how much effort is put into research that's done to help the patient, not just to do the job, but to help the patient. And I'm really appreciative of that, and some of the nice people that I've met, and they leave no stone unturned, and it makes me very happy to be part of that. That allows me to voice my feelings as a layperson, and it may make it better for other future patients.
So I do have a few reflections, having gone through this project, on what I would do differently next time. So I've already mentioned that I did not budget for Lux's time, and this is something that I am now doing. So I've just done a funding application where I have budgeted in for the consumer investigator's time. And there are now Queensland Health guidelines around appropriate remuneration for that. So if anyone's going through the Queensland health system, I can certainly point you in that direction. I would also consider having 2 consumers on any given project, from the perspective of them not feeling quite that pressure to speak for all consumers, but also that they might have a little bit of peer support amongst themselves. Unfortunately, we couldn't co-present as was the original plan due to COVID, but I'd love the opportunity to do that in person. And one other reflection I have is also around authorship. So Lux was listed as an author. However, I now would like to make sure that that was really clear in the affiliation. So this is an example of a research group in Brisbane where they make it really clear in the affiliations of the manuscript that there was a consumer investigator or co-researcher on board. So while this was mentioned in the manuscript itself, it's not in my affiliations of my manuscripts. And of course, hindsight being 2020, I would also go back to my mixed method study and actually have a consumer investigator in on that study, particularly to perhaps explore doing some co-interviewing around patient experiences. I think it would be really invaluable to have a consumer investigator there for that stage as well. So with that, I'd just like to really once again acknowledge Lux's amazing contribution to this project, my supervisory team, who were a great support and really encouraged this collaboration. I was part of the JCU doctoral cohort, of which I also learned about consumer engagement. Jo Shering is the Townsville HHS person-centered care lead, and she gave some really great advice. And the research support staff here at the hospital also really helped me navigate this. And so I'm happy to take questions at the end, or otherwise feel free to contact me via email. Thank you.
Thanks, Amy. Nice work. Yes, there's been some really interesting questions in the chat already for you, Amy. So I'm going to park them until we've finished hearing about Leah's talk, and then we'll address them too. But keep your questions rolling in, or just think about them for when you're interested at the end, and just raise your hand. That'd be good. Now I'm going to share. Leah, I'm sharing your screen for you.
Thank you. I had a technical difficulty and cannot share, so I will be asking Ray to move through the slides for me. Thanks, Ray.
All right. Are we good to go?
Good to go. So my name's Leah Hardiman. I've been a consumer representative for women's and newborn services for about 12 years. So I represent on various committees at national, state and a local level. I live in Brisbane and Metro North. So I might go to the next slide. I know Amy has already gone through a little bit of this with you, but I probably wanted to get a little bit more in depth about those 5 methods of engagement with your community, and talk about the advantages and disadvantages of this type of engagement, and sort of give you a real life perspective from my experience, having been a part of this work for a while. So if you do choose Inform to be your way of consulting and engaging, the information, I mean, it's a key part of what you do, but I think it's more about, that's the information that needs to reach a lot of people. And I'm not sure if it's probably the one that I would go with the least as your method of engagement. Consultation can be a really useful tool. It tends to be one-way information, maybe a focus group, a small group of people that is able to collaborate with other people. And it's not very time intensive to be consulted with. So that is a benefit from the community's perspective, is that it's not time intensive for us. Collaborate, I would say that the advantage of this, I think this is a great middle ground where there's still not a great deal of pressure on your community member. However, they are having more of a say in the design of your research. And therefore, I think there is more there is more chance of getting your research right if you are looking from this collaborate to co-design and moving into co-design. That's definitely more in an in-depth method. This takes a lot of time as well, and that's something to consider in your research. Do you have the time to build the relationships and actually work through what you need to with your community to achieve the outcome? And also co-design can be that little bit of a challenging space where you have an idea about the way something should be and where you want to get to, where you want your research to end up. And that can be pretty challenging from your community members' perspective or your patient and public member, is because they may have different goals to you. So I think that can become a place where you really have those robust, true conversations about what you're actually trying to achieve with your research. With a patient or public member leading research, the only times in my experience that I've seen this happen is usually if that person has a PhD, and because that is next level expectation of engagement. And if that is a project you want to set up, you would want to ensure that it was set up appropriately to support the person in that role. And that would come into how are you going to pay them? How do you understand the time that they're going to need? And I mean, you could co-lead as well. I know Ray and I had a recent discussion about co-design and leading, and at the moment I'm working on as a research assistant, but also as a consumer representative with regards to a guideline for gestational diabetes. And I think that it does sit in the co-design, but there's also some elements of lead. So it's about not necessarily being stuck on having a title for it as well. I do think that you can be quite flexible in what that co-design and what that lead looks like, because there might be some times where your patient and public member is actually better at leading something. And going on from what Amy just said before about co-interviewing, it makes your participants in your research very comfortable when they have someone sitting in the room who has an understanding and comes from the same layperson perspective that they come from. And it's also an opportunity for you to be able to ensure that the language that you're using is at an appropriate literacy level for the people that you're engaging with, or potentially maybe something could be done better with regards to interviewing, because that is not always an easy task, and we can walk away from a job thinking we've done it really well, but you don't really understand the feelings of the people who have just participated. So yeah, next slide. Thank you. So I guess I would hope at the aspirations for involving community would be at that community level, you're building good relationships. It's a way of forming excellent engagement, and it also ensures you can ensure that communication is both ways. So it's not just about sharing information, saying this is what we want to get to, this is how we want to get to it, but really respecting that there will be a different viewpoint. And that can sometimes be quite challenging, especially if you're a clinician working every day, seeing that something needs to happen, and you go to your community and they say, well, actually, that's not the way we want it to happen, or necessarily the question that we want to ask. We've actually got other priorities. That can be quite challenging. The aspiration would be building a trusting relationship with your community and doing that with integrity and transparency. And my experience is when you are at that co-design level, those things inherently happen because you have access to those people, unfettered access to the people that you're working with if you do work at that co-design level. And at the policy level, you know, the research that you're doing, potentially you're trying to change policy, potentially you're trying to change a guideline, the way things are being done through your research. So the research or project has the ability to drive policy change and quality improvement. But it's also important to understand whether it is the way the community wants it to go. An engaged community can also lobby for change if required, because we produce all of this research, we publish it, you've done all this really hard work, great outcomes in the data, and you feel like you are truly representing what needs to happen. However, it doesn't always happen at that policy level. So your community, when you have that trusting relationship with the community, they are going to be more likely to lobby for change. And ultimately, the end goal for everybody is about improving outcomes for the community. And it's about that shared understanding that we're all invested equally in this, in ensuring that we're delivering the care that people need. Thanks, Ray. Next slide. So what are some of the practical steps you can take? Because you hear from us all the time about what you should do, and this is what you should do, but how do you, what can you actually do to do this? And aim, I know there was a question in the chat, and also Amy touched on this, aim to recruit at least 2 community representatives. So there is a greater chance of maintaining engagement. The reason why I say this is that life happens to all of us. I work in women's and newborns, and it's a very changing, it's a very moving space in our life at that time where the baby didn't sleep last night, I cannot, or my baby is sick, I cannot attend a meeting today. And then you're going to have somebody else who is actually going to still be able to represent, most likely, on your behalf, and still be able to speak to you about that at a time that's more suitable for you. And there's another example. I work in women's and newborns, and we work on projects like stillbirth, preterm birth. We're trying to doing a preterm birth prevention project at the moment. And there's 2 consumers on there. There's myself, who has never experienced preterm birth or loss of a baby. And there's another consumer who has experienced a loss of a baby and preterm birth. So we actually come from very different perspectives, and it's important to be able to have that breadth of experiences at the table as well, because I come from a place where I do go into this quite fearless, yet the other consumer representative has, you know, and fair enough, fear attached to that. So spend time getting to know your representatives or your community members. Find out what time suits them for meetings and what time they have to review documents and provide feedback. So be very upfront about this is the time we expect to need from you. Do you think that's something that you can meet? And also, like, one of my bugbears is women's and newborns. We are having children. We're there because we've had children, and they schedule meetings every week at school pickup time. So, but when you actually schedule things and showing the people respect who you're needing to engage, then that does build a lot of trust as well, and respect, and you feel that you are valued in the part that you're doing. Something I would do as well is, when you do have these research meetings or any meeting, offer a pre-briefing and a post-brief meeting as well, to ensure that your patient and public representatives are able to understand your objectives, and that you can also get an understanding of theirs. So it can be expectation managing on both sides as well. Sometimes I can come into a meeting and think, this is what I want to achieve here, and I never get the opportunity to have that discussion. And that can be quite frustrating from my perspective, because I think it's really important, but other people at the table don't think it's important. And another thing to also, on top of that as well, is just be really aware of the power imbalance that potentially could exist in the room. As a community representative, I'm not a doctor, I'm not a nurse, I'm not a midwife, I don't bring clinical expertise to the table, but what I do bring is an in-depth knowledge of my community and what they're saying they want, and how they're saying they're affected by whatever the intervention is that you could be proposing in your research. So next slide. So my personal goal, and this is just remembering that I am just one person and that this is about really going back to your community and understanding what their goals are. But from my perspective, I think we need to move away from surveys and arm's length engagement. And to do that, and like you all do in all your clinical practice, it's that reflective practice about how you're doing things. So what are we actually trying to improve? What is your community saying? How do we know what the community is saying? What makes you nervous? I'm not saying that community engagement shouldn't make you nervous. There are things that should make you nervous. It is a little bit uncomfortable at times as well. And you can feel that they just don't understand things in the same way that you do, and they don't, because they're not delivering frontline care potentially the way you are, or they're not a researcher. So what have you done that works when you have engaged and you're getting really good feedback? That's a measure of success to potentially try for any future endeavours. And one of the things that does come up a lot, because I am involved in perinatal mortality subcommittee. We look at contributing factors for perinatal mortality, and I do get access to information that is clinical information that is confidential, and it is, and we all sign confidentiality agreements. And that should be an expectation of this, and I'm sure you all do. There are confidentiality agreements available for everybody, with the expectation that any information that you have is only to be shared within your group and not to be shared outside of that. And I think that can be a really gentle conversation to have, but I think it's a really important one, and one that actually no one has ever had with me, but I feel like I have a good understanding of. So in 12 years, no one has ever explicitly sat down with me and said, Leah, this is what confidentiality means. And I think it is important, because people walk away from meetings and think, oh, I've got to go and, or what can and what can't I say? So I think really tease that out with your community, because you still want them to go away and engage and ask those critical questions you want them to ask and understand, but at the same time, you don't want data shared. So be quite explicit about that, because you don't want to be losing your consumer representatives for something that could have been prevented as well. Next slide, please. Oh, thank you. So thank you so much for your time. And if there are any questions, my email and phone number are there, but we're going to take questions now. Just one thing I wanted to add that I did miss with regards to when you are doing your research as well, thematic analysis. I really think your community members are so valuable in your thematic analysis, because sometimes your themes are very different from the themes of the community. So that's just something to end on, but thank you.
Thanks, Leah. I might take the privilege then of asking you the first question, because it was in the chat, right? And it came up with Amy's talk, and now you've also reiterated that. Like, you both mentioned that Amy did content, you're talking about thematic, and that's really important. What happened in the chat was someone was, well, do they have to be trained in that kind of qualitative analysis? What are you thinking about there? Open to both of you.
I love consumers and I love community representatives who aren't trained, because it's there's this fine line, isn't there? And it does depend on what you're doing and your expectations. And if there isn't training, there needs to be a lot of support to understand the process of a thematic analysis and what we're actually trying to achieve here. But that's done through that relationship building, through that talking about, this is what we're going to do. We're using all these fancy words now, but what it actually means is, what are people saying? So it's about presenting things in a language that is understandable. I think there is some value in some training. If you're talking about at that HHS level where you're doing an orientation, though, that's very different to training. Doing an orientation to a health service is sort of like, oh, okay, yep, I know what a fire exit is. But when you get into the I think when you get into training, sometimes it can build up barriers from my experience I've seen. And I've trained about 180 consumer representatives in Australia for maternity care, for women's and newborn services. And what can also happen, though, is that they feel like I need to tell them what's the right and wrong answers and what their parameters are. And I think that is so much more valuable when you are having that lived experience in it. And the thing is that once someone experiences it once and you continue to work with them, that will naturally grow and build as well. So I wouldn't make it a prerequisite. Short answer, I wouldn't make it a prerequisite to be trained, because I think there's value in both.
And similarly, if I made that a prerequisite, I'd still be looking for a consumer investigator, I think, because I don't think my population, anybody has training in that. So it was very much train as we go for some of that real research methods requirements. And again, as I reflected, that also strengthened my understanding, because I was then working with Lux and explaining to Lux the process of content analysis, for example. So that's some of my reflections.
Does anybody want to ask something live at the moment? Because otherwise I can go to the chat. Thanks.
There are a few questions on the chat, Ray.
You want, yeah, I know there's a couple of questions on the chat. I've got one from Jenny. Did the consumer, no, yeah, it's another training question, I beg your pardon. It was about, did they have to go undergo consumer training from the HHS prior to being involved? So that's specific to you, I suppose, Amy.
Yeah, so here at Townsville HHS at the time, there wasn't research consumer specific training. So Lux underwent the orientation to the consumer HHS training, but he didn't undergo all of the specific consumer training, because it was all about, you know, committee activity, etc. That just wasn't as relevant in our situation. So I guess the answer there is he did a little bit of that HHS training, but then we adapted as we went along for our research project. He was also linked in with the consumer engagement group here, though, so he didn't end up using that, but he could have sought some extra support or peer support through that group. So that was one of the safeguards that we put in place, that he had that access as well.
And I think I just wanted to say, with your acronyms that get used in Queensland Health, one of the things that I found, though, I have for just women's and newborns 4 pages of acronyms. So when you use acronyms in your everyday language, and you're also used to doing it on your work meetings, if we had to look up every acronym, we wouldn't follow the conversation, to be honest. We wouldn't even understand what you're talking about. So maybe, you know, less jargon, and I think there's a slogan about that with health, less jargon will lead to better engagement, because the problem is that when you start speaking in that jargon, from our perspective, we go, oh my God, this is just too hard. I don't even know what they're talking about. I can't be here. And then you disengage, and you tend to do it quietly and not just say, I don't understand, because you don't want to feel stupid either.
That's a good point. I end up just feeling stupid because I do say I don't understand. And there are a lot of jargon. I totally understand. I want to look at Vinay's question. He asked about how would consumers prefer to be contacted by researchers keen on engaging in projects. He's particularly interested about modalities, phone, email, social media, and the process. So, you know, by researchers, organizations, existing forums. How would you go about making initial contacts, I suppose, in that space?
Use every single one of those things. Basically, unless you have a really targeted group that have already formed, that have approached you. So that happens a lot in maternity, to be honest. Maternity consumers are very engaged, and so that's from my, like, we're banging on the door at the health services and researchers to be involved in things. However, depending on what it is, it can be that, you know, if it's diabetes, go to the Diabetes Queensland. If it is whatever, if there is an organisation who you can identify as someone that you could seek support from and help with, they will be engaged with their community with regards to that condition. And most, like the Heart Foundation, they usually have consumer advisory groups as well. So you could go through them, go through your PHN. It's mandated that they have consumer advisory councils in your PHN. So reach out to them, because it's often a breadth of experience then. And your HHSs all have to have community advisory groups as well. So, and then interrogate if there's any further subgroups underneath them. And if that's about engaging, but then when you do start to engage, use the phone as often as possible. It's hard to be on email all the time. Consumers aren't sitting in front of their computers like everybody else is, to be honest. We're not doing that. We're trying not to anyway. So But the process of recruiting, I'm not going to pretend for one moment that it's easy, because I don't think it is, and to maintain engagement. But that's where that minimum of 2 consumers comes in. Consumers, I don't even like that word. The minimum of 2 community representatives comes in.
Cool. Okay. Didn't know that. Amy, you uniquely had that opportunity. How did you do it?
Yeah, so as I briefly mentioned, we specifically sent out letter of invites to the previous 5 patients who had experienced what we wanted to study. And that was because I'd initially gone to the consumer engagement lead here, and we didn't have anybody already identified who met that lived experience criteria. So I agree, reach out in as many forms as possible, but also reach out via snail mail, because you might be unnecessarily biasing to those who are tech savvy. So depending on what your research topic is, also consider that not everybody has social media, not everybody's on the computer, as Leah said, all the time. So depending on the needs for your consumer.
And I might add to that, something that Leah and I did several years ago, again, still working in gestational diabetes. When Leah and I and others co-designed a project together, we had a bit of money. So it's unusual, but we had a bit of money. So what we were able to do was to hire a company who did random digit dialing. So we told them the type of person, you know, we had an age group that we needed. We had particular criteria that we needed them to be, like, we're talking about gestational diabetes and we're talking about screening, right? So we needed them to be in the age group of childbearing years. We needed them to not have gestational diabetes. We had a long list of things that they needed to be or not to be. And they did a lot of the recruitment for us. So we just got fed people who were interested in stuff. But again, like I said, that did take a bit of money, but that randomness was super important for us. And we were able to get the company also to go for different ruralities as well. So we used that, the differences, the diversity in that too. So that was important to us, but we were fortunate to have some money. And I'll stop speaking, but I just want to go back to the chat where Magnolia has asked a particular question of you, Leah, and it is a researcher question that us nerdy researchers get worried about, right? Is that what if there's no evidence for the activities or components that the consumers are suggesting we might want to look at? And how do the clinicians, researchers manage a relationship without seeming patronizing?
Yeah. Oh, and that can be tricky, but I actually think that's well managed most of the time. I actually had a lived experience of this recently where every CI was like, well, this is the way I want it to be. And I'm like, I actually think that's too risky. And look, they did disengage, because so there are all different things you can do. You can choose not to engage with that person because they don't agree with you. But I think you can always meet a middle ground, and it's about increasing their knowledge in that space. So I can say, so in what's really contentious in, sort of our area is that is what safe care, what level facility provides safe care, what does safe look like? And safe looks all different depending on who you're talking about. And we're often seeing now people accepting the social determinants of health, which hasn't historically been done really well. So an example of this is Central Queensland at the moment, with Gladstone having lost their maternity services on bypass for nearly a year, or for 250 days. And there was conjecture around, well, is it safe to open this service at level 2, which would be midwife only care, or not? And the thing is that and so people, even when there is evidence, because there is evidence around that, but even then people don't agree. So it is tricky, but I think if you are just having those conversations, it doesn't need to be patronizing. Step through what the barriers are with your community members. Say, this is what we have found, and also be really aware during that conversation of potentially what your experiences had limited your aspirations to be as well. So potentially you could be like, I've tried this before and haven't been able to get there. I don't think we can do it. And then but a community member comes along and goes, but it's what we want. So let's do something about it and let's try. So I just think it's about keeping that conversation open. I would encourage to keep engaging. And at the end of the day, there is no way I ever get my own way all the time on everything I want to do. And I think we do understand that, and we do understand that you can only do so much in your position as well. Like, we do understand the big cog that exists, and that we would love to change things quickly and it doesn't happen. So I just think it's always in your delivery, and just that using that language, like, I understand, I would love to be able to get to this as well, or maybe you don't agree with it and say, but then explain your perspective. Yeah, it's really a case by case basis, that one. And if need be, have someone else come into the conversation as well. Really broaden that conversation if you think there's more information that's needed, without being coercive.
Good point.
Or bringing more people in to say, see why your idea doesn't matter. Yeah.
Good point.
It's a tricky balance.
It is. And it reminded me too that one of the reasons that this is so risky, this strategy, this engagement strategy is so risky for people who have positions, particularly, in policy and potentially guidelines, things like that, is that by inviting different perspectives, you are actually intrinsically saying that you don't, nor should you, have all the answers, I think. And I think that is a risky thing for many people to do, to give over, or to at least share that power. I think that it's a new experience still, and I think it's still being played out. But I think, certainly from my perspective and Amy's and Leah's too, is that when you do give that over, it's so much more enriching. And Amy, I have a question for you that I'm interested in, because you said that as a great student, as a wonderful PhD student, as soon as you heard that you had to do in consumer engagement, you digested every little bit of information you possibly could get. My question to you, Amy, is, did it help?
Yes and no, because what I needed, and it's what I'm writing right now with some collaborators, is engagement is great as an abstract idea, but how do I do it? What are those steps? And that's why I'm very happy to share the steps that I went through, because particularly for clinician researchers, it's not often done. It's done more so in academia, I think, than in hospitals, for example. So it was great for the theoretical, but the practical was missing in the literature. And this, it continues to grow. So in the last few years since I embarked on this, there's a lot more onus on clinician researchers to involve consumers. So you do see a lot more coming out. So I think it is a changing landscape for the better, which is great. But yeah, that was my experience at the time.
Do you want to add, Leah?
Oh, I think Amy covered that well.
Me too.
Amy covered that well.
Now, just a heads up, there's some interesting resources that are on the chat, but I've also should at this point in time make sure that I share the screen again to just let you know that there are some other resources here too. That's quite a lot of different bits and pieces, but it goes to Amy's point though. There are a lot of resources out there that tell you the principles of it and the things that should be done, but very, very few of them tell you how. And one of my PhD students is actually looking at the how. It's like, she's actually going to all these guidelines and said, yes, we've done it, ta-da. And we can't even figure out who they are. Like, who did you talk to? Like, that was question number one. So Amy's right. There's a lot of resources about the what. There's very little about the how. Does anybody have a live question that they'd like to ask?
Magnolia does have a question in the chat
Yes.
that I thought was good. The one about, can the consumers be qualified on a topic, example masters? I say yes, absolutely, to be honest. Like, of course, they're going to come from a very high level understanding, but I would not, the only reason you would exclude them is because if they were clinical and providing frontline care and had that potential conflict of interest, as in they've been a researcher that's been really interested in this topic. This has come up recently. I work with a woman named Beck Jenkinson who has done her PhD, and it resulted in her leading, so the time when someone did, first time a consumer has ever led a guideline, and that was for declining recommended care in maternity. So there has been conjecture, and someone has recently said, I think you need to step away from consumer representative role because you have your PhD. I wholeheartedly disagree with that. I think I think what you would need, what I would do in that scenario is if that what you did choose, then definitely choose someone who doesn't as well. If you're going to have those two, have someone with that high level of understanding on a different level and with their own embedded limitations as well, because they are so well researched. They tend to, after doing this for 12 years, you tend to get quite indoctrinated into all of it. It's not the right word, but you're institutionalized. I don't know which one's worse, but it is. It's a form of institutionalization where I sit on a committee or a group or a research project and I go, oh, I know we've tried this before, it didn't work. I'm not even going to mention it. Whereas you get someone new come in with some new ideas, and it just reminds me when it happens, just, oh my God, I used to be like you. I was so hopeful. You know?
You still strike me as hopeful, Leah. Which brings me to another question.
This afternoon.
Another question I had, speaking of hopeful, I say I'm asking with some crossed fingers, so I'll own that prejudice right now. You have been a consumer rep, as you just alluded to, for quite some time. Have you seen any changes or progress with us kerfuddled clinician and researchers?
Definitely.
Have we done any good?
Definitely. There's been so much good, and it's easy to like hang on to the bad stuff that you didn't win, to be honest, from my perspective. But I see some really good initiatives, some really good quality improvement, and ultimately our clinicians, like when you really get into the core of it, they're all trying to do their absolute best for us, and they are working towards and becoming involved in research projects, like probably everybody on this call wants to. So yes, absolutely. I've seen many quality improvement and collaboratives happen that I think are improving outcomes and providing us care that we've asked for. I've seen the opposite as well, but it has worked. And the consumer engagement, it's through the roof. Like I don't even have enough hours in my day to be able to help everybody I'd like to help and to answer every email I'd like to in the meaningful way. So that's changed a lot over 12 years. I think NHMRC and the Commission have had a fair bit of input in that.
Fair enough. I'm going to end on a question on the chat for the both of you. What strategies would you suggest for engaging consumers who do not have the same level of literacy and or other skills that we usually find in consumers who often nominate to contribute? So I guess you're looking for the populations who are seldom heard, I suppose, but they will undoubtedly have a different experience. How do you reach them? How do you include them? What could we do?
So Steph, I think, is that you in Mount Isa? Are you on this call? Don't know if you're going to want to unmute.
Hello.
Sorry to call you out. Hey, Steph. I just thought I'd call you into this one, Steph.
Oh, lucky you,
like,
Steph. Welcome.
I saw you. I'm like, I'm sure. I know that's your country. You had that written there. So, yeah. I mean, so Steph was on the Rural Maternity Task Force for Queensland. So Steph, I mean, what did you think about that? Did you think that, because we wanted to engage, like, I was engaging First Nations people, right? So, I mean, what did you think?
Yeah, so thanks for letting me have a yarn.
Put you on the spot. Do you think that was done well, Steph?
Yeah, definitely. And I think like there's lots that needs the like there's a lot more work to be done, but I think like that there have been a lot of opportunities for like consumers to be involved and have those conversations and be a part of those, like the, you know, to be able to feed back, you know, like their experiences and, you know, their stories, and being able to be involved in a lot of, you know, that work. I think what helps best for like talk, you know, making sure that we include our vulnerable groups, and as well as, you know, like having those conversations with people in the community, you know, building those relationships, and, you know, having those open lines of communication, and you know, yarning about, you know, sharing their stories, so welcoming them in, sharing, you know, like getting, you know, building that trust where they're able to, you know, share their stories, but also like, you know, like, you know, sharing your story as well, like what, you know, like what you do as a consumer, but, you know, like you're also a consumer as well, you know, like, and, you know, you have these rights as well, and you know, like I think a lot of people in the community don't know about what their rights are as consumers, you know, as patients, and you know, and also like, you know, so bringing them along on that journey too, you know, like we can help have those conversations, and you know, get people to engage in different ways or to share that information. You know, we can also, with their permission, share their stories for them, you know, like, and say that, but, you know, that's another way, but it's also about that, you know, yeah, building people's capacity as well, and you know, learning all about this, you know, the systems or the health, you know, all of the different groups and the health terminology and all of these, you know, so yeah, it's yeah, this
so
is
Steph,
about,
you had to represent a lot of people on that rural maternity task force, and you did have, and you engaged in different ways by traveling around and actually being there, didn't you? That was,
yeah, so
that was valuable.
Yeah, I was able to share my experiences as a mum, and what I've experienced, but I shared like I was sharing my story, but you know, I speak for and share my experiences, and I do acknowledge that there are other, you know, like there are women in the communities who I can't, you know, I don't represent or can talk for. So what Amy's talking about, you know, how sorry, Lux was feeling. I feel that same way. I cannot share stories from like their perspective or experiences, but I mean, with their permission and that, I'm happy, and like if they wanted me to, I could, but I also couldn't speak for a community, you know, like, so I was always about like, you know, making sure that we have consumers from all those from their community, you know, talking about sharing their stories and talking about their, you know, engaging and being involved in, you know, but recognizing there's a lot going on, you know.
And that those conversations are just as important as reviewing a document, aren't they, Steph? Like that, so that, and when we talk about the literacy level and even access to internet, and it's about that face-to-face. So sorry to put you on the spot then, Steph. I saw you there and I was just like, it was just, I know that you had that lived experience of actually having to go around and speak to people, and everything doesn't have to be in the written form.
That's a really good point. And Steph, you did great for being on the spot.
Thanks, Steph, sorry.
Leah, you were in trouble, Leah.
I got excited because I saw your name there, Steph, and I was like, it's been so long.
But thank you very, very much. And I think that speaks to, I mean, I really think that's the way to end this. It really is about trust and respect, and making sure that those are front and center principles of any engagement activity that any of us, you know, no matter what we do, actually are about. So thank you all for joining today. Thank you very much, Leah. Thank you very much, Amy. Every time I have conversations, I learn something new. I really appreciate it. So thank you. Have a great day, everyone. See you later.
Thank you. Bye-bye.